The article we have today is applying the risk needs responsivity model to the juvenile justice system. We're going to start with a history of the risk needs responsivity model. So the juvenile system was originally designed to rehabilitate the wayward youth, and this was intended to protect the youth and the public and save them from a downward career. These screening instruments were used as early as the 20th century, but didn't gain traction until the mid-century, with researchers attempting to develop tools for this structured decision-making. With these tools, they wanted to determine and address factors that contributed to delinquency, but over time, these goals seemed to conflict, and rising crime rates were blamed on rehabilitative approach that was taken with these youth. Individualized rehabilitation was lost, and the one-size-fits-all model was adopted. The new approach led to a significant increase in the number of youth in the juvenile justice system, and many of them being classified and treated as adults and even given harsher sentences. The juvenile justice system became more of a retribution focused with less individual treatment for each juvenile. In the first half of the 20th century, offender risk for both adult and juvenile relied almost entirely on professional judgment. In the 1970s, risk assessment began to replace unstructured professional judgment and has consistently shown to outperform clinical professional judgment in predicting risk, although they were still faced with criticism for lacking a theoretical basis. They also relied heavily on static risk factors, such as criminal history variables, and in response to this, risk models began to use dynamic risk factors, those that correlated with future offending, amiable to change, and could be targeted through interventions. We began to develop some new models, and these models took into account the changing nature of factors that were relevant to risk. This included occupational, family, social, and substance use. The changes in the scores could better predict the changes in recidivism. Unfortunately, these tools did not take into account the aspects relevant to case management and the factors that influence effectiveness of interventions. They moved toward developing comprehensive assessment tools that considered factors relevant to their treatment. These tools had been significantly influenced by the risk needs responsivity approach with the assessment and treatment of individuals in the justice system. The realization that the push for retribution had increased prison growth as well as failed to reduce recidivism with minimal benefit to society, and this left them wanting to return to the individualized approaches that they had with an emphasis on offender rehabilitation. This brings us to the RNR model, and it's well developed in the adult correctional research, but is still underway for the juvenile justice system. The approach for this is a decrease in recidivism, determine offender risk. They also consider specific factors related to responsivity to treatment when matching interventions to each individual's needs. Matching the risk for recidivism can help to classify low, moderate, or high risk groups of the individuals. More resources are devoted to those in the high risk category, and this would help to see who may make a significant change opposed to those who are unlikely to reoffend. And with this model, we will develop focus of needs and then addressing those needs. There are 8 domains to the RNR model. There is pro-criminal attitude, antisocial personality, pro-criminal associates, history of antisocial behavior, substance abuse, circumstances pertaining to family or marital problems, school or work problems, leisure and recreational problems. Next is the focus on the individual's strengths and deficits that may affect them and their treatment. They're going to apply the evidence-based approaches and build strong therapeutic relationships with their clients. They will also use a CBT approach, and responsivity is tailored to their learning style and ability. Also, motivation will be taken into account. Underlying the RNR model is the theoretical approach, which is the personal, interpersonal, and community reinforcement. This says that the criminal activity develops through social contact and those not opposed to antisocial behavior. So it is then reinforced through operant and classical conditioning, which rewards associated with this behavior contribute to continuation of offending behavior. Studies found that appropriate interventions per individual had a greater reduction in recidivism, and those who were high risk had substantially greater reductions in the recidivism. The RNR models for juveniles focus on the developmental differences and how they should be taken into account. The therapeutic approaches and interventions offering services that address various needs have been found to be more effective in reducing recidivism among youth than attempts to control their behavior. There have been several risk needs assessments created, and there is still discussion on how these can be modified to take into account youth-specific needs or how empirically based interventions targeting youth-specific factors might be developed in adherence to the principles underlying the RNR model. So risk factors would be taken into account, assess for empirically supported factors, developmental limitations. They also guide the treatment planning with flexibility and practicality. And still more testing needs to be done to examine risk assessment tools and evidence-based interventions. Currently, there is only one empirical study that has examined the full RNR model in a juvenile justice setting with similar findings. So the research, some evidence is that when a risk assessment is conducted, determinations of level of risk influence decisions about level of intervention in probation setting, and these are findings that align with the RNR principles. They also found that the risk principle was not always applied, as detention decisions appear to be related to offense history and the presiding judge more than to their risk level. This really represents a barrier to adherence to the risk principle, as when risk assessments are available, individual judges may not consider the juvenile's identified risk as a significant factor. Despite this barrier, substantial evidence suggests that the greatest treatment-related reductions in recidivism occur for youth with the highest risk of delinquency, which suggests the importance of the risk principle in practice. So let's look at the needs. These represent criminogenic needs in juveniles identified family factors, social factors, and delinquent peers, their leisure time, conduct problems, and non-severe pathology such as stress and anxiety as key areas of interest. Youth on probation had several needs in the domains of education, employment, family, substance abuse, peer relationships, personality, anger management, their leisure time, antisocial attitudes, and that addressing those needs led to a significant decrease in recidivism. Identifying some of these needs may be a problem. First, decision makers may over-identify needs in that youth who have low needs in a particular area may be deemed to have a high need, and they will receive interventions for unneeded domains. Second, assigning treatments that address dynamic risk factors irrelevant to a particular youth divert scarce and costly resources away from those juvenile offenders most in need of these services. And finally, research also suggests that criminogenic risk factors may shift away from certain domains and into other domains as the youth age and develop, which means age needs to be considered. And to our knowledge, no studies have examined the responsivity principle in isolation among juveniles. It was also noticed that some programs emphasizing discipline and deterrence actually increased recidivism, while programs emphasizing surveillance reduced recidivism. However, these programs were less effective than those programs with a therapeutic focus. So some risk assessments identified factors related to the risk, need, and the responsivity are varied and represent several different areas of life. For example, substance abuse might represent a criminogenic need, and mental health concerns might affect an individual's responsivity to treatment. And as a result of this, to adhere to the RNR model, justice-involved youth should undergo a multifaceted critical risk needs assessment. The tools and their primary purpose is to assist juvenile justice agencies in improving resource allocation, to convey useful details regarding risk and need levels of each juvenile client to juvenile justice agencies, and to provide general guidance during the intervention planning. We have some risk assessment tools. The first one is the YLS-CMI. It's often identified as the most widely used and most commonly researched risk need assessment for juvenile offenders. It's an instrument meant to be completed by probation officers and or mental health professionals who have minimal training. This is classifying youth as within one of the 4 risk categories, so low, moderate, high, and very high. This has been identified as too cumbersome for regular use within the juvenile justice system and originally had 112 items they had to go through. Our current version has a 42-item checklist. It measures offense, history, family circumstances or parenting, education, peer relations, substance abuse, leisure and recreation, personality or behavior, and attitudes. It has also shown reliability between probation officers and mental health professionals, supporting use of the tool in a variety of settings. It really sets apart from other risk needs assessments, so its addition of a case planning tool, which combines information about criminogenic needs and responsivity factors to identify proper service intensity recommendations and offer suggestions for future intervention targets. The next one is identified as the SAVRI, and it's the SPJ tool. It's modeled after the Historical Clinical Risk 20, so the HCR 20, and it's an adult measure predicting violent behavior. It has a focus on historical, social, contextual, and individual clinical risk factors empirically associated with violent behavior and recidivism in adults. It's rated on a 3-point scale. It evaluates the presence or absence of 6 protective factors, providing more of an emphasis on resiliency. This tool also discourages using the sum of the scores alone as a determining factor of youth risk level, and instead instructs assessors to review the identified factors as a whole and make a final professional determination of low, moderate, or high risk for the individual. It also demonstrates strong predictive validity for general violent behavior and over 1 and 3 year follow-up periods. Its research is less prevalent than the YLS-CMI research as a result of its more recent development. So after somebody has taken one of these risk assessments, they are assigned a risk level, and once their criminogenic needs are identified, they must receive ongoing individualized treatment specific to their risk level, their needs, and capabilities. The model prescribes only the use of empirically supported treatments, but limited available research supports interventions that target maladaptive thought process. They enhance problem-solving skills and regulate impulsive behavior, especially with juveniles at higher risk for recidivism. Treating youth with behavioral issues included multi-systematic therapy, functional family therapy, and multidimensional treatment foster care as 3 model programs for adolescent offenders with adequate support in the literature. These interventions have been successfully implemented with justice-involved youth for varying risk levels, and they often seem to be the most effective at reducing behavioral problems and recidivism rates in youth with high risk of future delinquent behavior. The MST was developed in the 1980s, and it serves youth at risk for out-of-home placements and their families in the community, with an emphasis on individualized treatment plans that take into account the strengths and weaknesses of the youth and the youth's family and environment. The MST therapists work in teams and carry a small caseload, making themselves available to the client's families 24 hours a day. They utilize the intensive contact over a 3 to 5 month period, and the therapists develop an understanding of the functional basis of the youth behavioral problems, and they work with the families to restructure the youth's environment across several systems to facilitate the pro-social behavior that we're looking for and reduce the antisocial behavior. The MSTs targets cognitive and systematic factors linked to antisocial behavior using present-focused and action-oriented interventions. Some examples of MST facilitated changes in specific systems include removing the youth from deviant peer groups and facilitating friendships with pro-social peers. So this is improving their peer social network. Enrolling the youth in job skills or classes to enhance capacity for future employment. So this involves improving the school or vocational system, and teaching parents the skills needed to supervise and monitor the youth in the future while removing barriers to successful parenting like parental drug use, mental health issues, and low social support. It was found that its use reduced the rates compared to individual therapy and other typical court services, with fewer rearrests and less time spent in adult detention facilities throughout a nearly 14-year average follow-up period. MST also demonstrated improvements in factors not directly related to recidivism in youth with a history of chronic violent, delinquent, and antisocial behaviors, including more reported family warmth and cohesion with decreased youth aggression with peers. So then we have the FFT, which is the family-based intervention. This is typically implemented with moderate to high-risk youth. The FFT differs from the MST in that it focuses solely on the family system dynamics during much of the treatment program, and it waits until near the end of the treatment implementation to generalize skills to other potential problem areas. The FFT therapists view the family as one entity, and problems are attributed to relational issues generally rather than any individual family members. The program implementation typically involves between 12 and 30 family visits within a 90-day period, and it really is dependent upon each specific family's needs, and therapists maintain caseloads of about 10 to 12 families at one time. They try to develop the family's motivation and hope for change. They try to enhance individual members' inner strengths and foster greater self-sufficiency and self-respect. They have a really flexible structure with 3 phases. The FFT starts by maximizing the positive responsivity factors and refraining maladaptive beliefs to increase hope and decrease resistance. This moves on to develop individualized behavior change plans for each family member, and it finally helps the family to apply positive change to other situations like school, work, their community, or even in the juvenile justice system. The FFT therapists work with families to increase the communication, improve problem-solving skills, establish clear rules and consequences for the youth behavior, and provide rewards for pro-social behavior. Then we have the MTFC. This is a social learning-based treatment for children and adolescents with chronic delinquency and antisocial behavioral issues. The MTFC focuses on behavioral management techniques, and it often serves as an alternative to residential care for juvenile justice facility commitment by placing youth with a highly trained and supervised foster family. This is a hope to reduce the delinquent behavior and increase the pro-social engagement in developmentally appropriate activities, and ultimately return the foster youth back to their original homes. The MTFC seeks to create a therapeutic and structured family environment for youth with parents that implement individualized behavior management programs. They closely supervise the youth's daily behaviors, and they delineate fair and consistent consequences for antisocial behavior, and they try to positively reinforce pro-social behavior and limit a youth's exposure to delinquent peers. So this program lasts for 9 to 6 months, and they attend school regularly and participate in individual and family therapy with their pre-MTFC families. In addition to this, monitoring the youth, they watch their homework completion, attendance, and behavior in school. And the MTFC parents, they must make daily reports to case managers regarding their child's progress and identify the problems, and maintain a close contact with behavior support specialists and physicians, as well as teachers, probation, parole officers, and work if they have it. So some theoretical criticisms that people have is that one, too narrow of a focus on the dynamic factors or criminogenic needs relevant to risk reduction. So it's necessary but not a sufficient treatment aim. The second one is insufficient attention is paid to the impact of non-criminogenic needs on rehabilitation. Third, a tenuous theoretical relationship among its principal components, which marginalizes the importance of the responsivity principle and offender rehabilitation. Some also say that it's too gender neutral, which is too similar for the males and the females. The one-size-fits-all model, it fails to consider individual differences among the offenders. And cookie cutter, which is the overuse of manuals, and every program kind of looks the same. Also, the poor treatment response, the low motivation for change, distrust, non-compliance, and increased anger and impulsivity. Some critics have suggested that application of the Good Lives model of offender rehabilitation is a positive, strengths-based, and restorative alternative to the RNR model, and it might be a better match for juveniles. The Good Lives model for the offenders argued that much of the psychological models of motivation based on non-criminal populations and that utilization of these principles must be operationalized and tested within the criminal populations. The Good Lives model takes too passive of an approach in promoting pro-social lifestyles and places too much emphasis on the pursuit of well-being, which ignores an individual's understanding of the major risk factors for crime. Also, enhancing an offender's pursuit for human goods may improve an offender's overall well-being, but the route taken for this pursuit may be harmful to society. Some practice criticisms for this is the impact of the RNR model might not be completely realized if it is inappropriately applied. Inadequate training of staff in the use of the risk need assessment may also impede successful translation of the risk need, and it results into practice. So assessors overclassify the needs, especially in common problem areas for justice-involved youth, and also the bias toward particular types of treatments and assumptions of treatment efficacy, promoting effects of unneeded treatments such as deviancy training. In conclusion, if applied appropriately, the RNR model can be instrumental in reducing recidivism. The RNR model has advantages for juvenile justice and adult correctional systems because it promotes a better allocation of services, specifically by applying more resources to moderate and high-risk offenders. Systems can keep lower risk cases out of intensive, costly correctional services that may cause more harm than good. The RNR model also promotes recidivism reduction on an individual level as treatments are tailored to each youth's unique risk and needs profile by maximizing his or her potential to respond to treatment and increase pro-social pursuits instead of fueling criminal pursuits.